Major funding for Carolina Business Review is provided by Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. And by Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries.
Well, it is clear that the hotly contested Affordable Health Care Act has salient points on both sides of any argument around it, but it is the law of the land now. That does not take away, however, the very murky projections of how it will change the cellular makeup of health care delivery in the U.S. Add into all that the mix that both North and South Carolina are declining to accept federal funds to expand Medicaid, and the future for health care is even more unsure. Welcome again to the most widely watched source for Carolina business and public policy, seen throughout the Carolinas for more than 2 decades now. I'm Chris William, and there are real questions how the General Assembly in Raleigh and the State House in Columbia will fund and administer health care costs for the poor in light of refusing monetary help from Washington. We will start this discussion in just a moment with our panel of experts. Please stay with us.
Major funding also by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, health care, rural churches, and children's services. And by Blue Cross and Blue Shield of North Carolina. Who's responsible for rising health care costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. This edition of Carolina Business Review was recorded March 22, 2013. On this week's program, Anthony Keck of the South Carolina Department of Health and Human Services, Dr. John McConnell of Wake Forest Baptist Medical Center, Dr. Angelo Sinopoli of Greenville Health System, and Michael Tarwater of Carolina's Healthcare System.
Hello, welcome to our program. Never a dull moment around healthcare. Gentlemen, nice to have you here, and thank you. Welcome back to some, and welcome, Angelo, for the first one. Secretary Keck, you get the first pitch for better for worse. Here we are. Just briefly, let me lay this out. Of course, I know you know this, but in North and South Carolina, there are about 1 million souls who would benefit from some type of Medicaid funding. In South Carolina, you all have decided not to take Medicaid funding. It seems like the low-hanging fruit here, Tony, would be to take the money. Why not?
Well, I think the premise of the Affordable Care Act is that more money actually means more health, and actually all the research shows just the opposite. 2 points. One, it's very clear that out-of-control healthcare spending is depressing economic growth, wage growth, and hiring in the United States. That's fairly well accepted. The second is that health and well-being are primarily determined by what are known as social determinants, which are income, education, personal choices, community supports, and only 10 to 20% by healthcare services. And so when you're a state and you're trying to put together a global budget about how to care for the well-being of all of your citizens, you can't just think about health care. You have to think about education. You have to think about job growth. You have to think about infrastructure investment. And groups like the Institute of Medicine have said that out-of-control healthcare spending is forcing states to divest in areas that actually improve health the most, such as job growth and education. So we think there's a better way. There's a misconception that there are no services and no money for individuals who are right now uninsured, but that's just not true. We spend several $100 million a year, not through an insurance model, but through different ways to get people who don't have insurance health. And in many ways, with a few tweaks, that system can be preferable to a Medicaid model.
There's a proposal in Arkansas about applying for the federal dollars and using that money to use a private insurer to cover these folks. Is that a viable alternative? Does South Carolina put their arms around that?
Well, I consider that alternative sort of Medicaid expansion on steroids because it's bigger and dumber. And the reason I say that is because it's taking a private insurance model to deliver Medicaid services, but it's actually more expensive. Already in Arkansas, through the analysis, it's 15% more expensive. The Congressional Budget Office says that on average it might be 50% more expensive because of the way these private insurance plans are structured and the rates they pay. So not only would it be more expensive than just traditional Medicaid, you still have to wrap around a set of services that are required by Medicaid. So you'd actually have two programs running right alongside each other, a Medicaid program and a private insurance program, and it's administratively more complex. So that's not really a solution. And again, it goes down the path that more money and an insurance-based model are necessarily the best way to get health care to poor populations. And in South Carolina, we are focusing more on what are the health needs as opposed to simply a broad-based expansion of the Medicaid insurance model.
Thank you, Mr. Secretary. Michael, in North Carolina, Governor Pat McCrory has come out and said that basically the same thing. They don't want to take the Medicaid dollars. We did contact Secretary Vaush at Health and Human Services in North Carolina, wasn't able to get a commitment for this program. Does this, when you look at this problem, does it already tax, and I think I know the answer to this, is not meant to be a leading question, but does it already put more uncertainty on the future of how healthcare providers like your hospital go forward to do what you're trying to do?
Sure it does. When the Affordable Care Act was passed back in 2010, providers began a series of cuts to their payments from federal programs, Medicare principally, to in part fund the back end of what the Affordable Care Act contemplated, which was these exchanges and Medicaid expansion and that sort of thing. So that coupled with taxes paid by citizens who live in both North and South Carolina, and in fact in every state, increased taxes were supposed to fund these expansion programs. So you know, we do see a lot of people who do not have any type of coverage. And even with the Affordable Care Act and all that it entails, there's still a fair number of people left who would not have been covered even with the exchanges and expansion. Now, the visibility in the field that I happen to be in, which is on the provider side of healthcare, is not improving. And you know, there are questions about, okay, so what's going to happen with these folks who are scheduled to get some kind of coverage? In North and South Carolina have made decisions, but I would tell you that in North Carolina at least, and Tony would have to speak for his state, but in North Carolina, you know, there was some concerns about the way Medicaid was being operated. We all agree that health care needs to be reformed, the delivery of health care. But most of the programs and the responses to, whether it's political or fiscal, most of the efforts are payment reform. There's really not a lot being done on delivery reform. So we put
delivery of the service.
The delivery of the service. Basically functionally redesigning the way that care is delivered to make it more affordable, to do some of the things that the Secretary's talking about in terms of you know, prevention and wellness and having people take more responsibility for their care. But you can't cut your way to that road. And in North Carolina, both the governor and the legislature have indicated to us that while they have made the decision that they made that we know about now, that they have said that, you know, they want to sit down at the table, they want to understand this better, and the door's not completely closed. And so we are working with them. In fact, John could tell you or weigh on this as well, but the hospital field in North Carolina has been to the leadership in the legislature and to the governor early on, and we've been repeatedly, and we've said we want to partner with you to try to structurally change Medicaid and the way it's delivered so that we can lower the cost. And already in North Carolina, according to a Kaiser Family Foundation study, The rate of increase in North Carolina over the last couple of years is the lowest of any of 50 states in the District of Columbia. So some of the things we're already doing are beginning to bend that cost curve in the right direction.
And some of these interventions really involve partnerships between health systems, hospitals, providers, and the very social networks you were referring to, Secretary. And the concern I have is, unless you would feel otherwise, I don't have any expectation that current models of addressing those societal issues are really getting any traction right now in terms of actual improvements. The communities where this is working, hospitals, physicians are partnering with those community networks through churches and through other mechanisms. We're now funding that ourselves, at least in our system, and Mike, I know you're doing that as well, probably doing it in Greenville. We need those resources in order to redesign the care, because it isn't just about care delivery, it's on the prevention side, as you know. And we're absolutely committed to being able to do that. But if we have further cuts, we will not have the resources to be able to do what really will transform care.
Mm-hmm. And I think, and again, I can't speak for North Carolina. I can speak for South Carolina and what the House has passed in terms of the budget. And
the House isn't all on one side of this. I mean, they seem fairly split between this decision, don't they?
The budget passed with an overwhelming vote, I think 116-1, but the portion about Medicaid expansion was rejected essentially along a party line vote. Okay. Of all Republicans voted for what we call the Republican alternative. But it goes to this point of actually changing the delivery system and using community networks and partnership. And in South Carolina, we're not cutting provider rates. That's one of the things that we think is most problematic, that a lot of other states who are actually expanding are expanding and cutting provider rates at the same time. And so the alternative that we've put forth includes a significant amount of money to actually flow into hospitals and to clinics so they can create partnerships that work on the populations that have the most need. And they're actually to participate in a program that makes available about $40 million next year mainly for hospitals. They're going to have to come to the agency with a plan on how they're focusing on the needs of their community to reduce costs and improve health outcomes, with a specific focus on people who show up at the ER without insurance and with chronic problems. So we're actually investing in those strategies, and it's building on some of the work that the Duke Endowment has done in a program called Healthy Access in South Carolina. And so we think those targeted investments are smart, because we do believe you can't cut your way to transformation. Cuts need to be made. If you believe the Institute of Medicine's a third of all healthcare spending is waste, there is room to cut, but you've got to be able to help people transition to get that cost out of the system.
Angelo, where do you guys come down on this?
So I think both arguments are right. I think, and obviously in a resource-rich environment, we'd like to have both, Medicaid payment and money for developing programs. I think if I had to choose between the two, I agree with Tony that the decisions that affect somebody's health really aren't made in a physician's office. And what we found in Greenville, and we've had a number of projects addressing the community needs for the underfunded, it's really been social determinants of care. That's what brings them back to the ER over and over. That's what creates our expense in the ER, our hospital expense, the readmission rates. So we've worked, and really what we've found is really around care coordination, care management, transportation services, working with the free clinics, with the federally funded clinics, with other resources in the community. And some of the projects we've done just addressing the social determinants of care, we've been able to decrease emergency room visits in our high-risk populations by 45%, decreased hospitalizations by 55%. And so I think those are valid points, is that really working with an integrated delivery system and working in the community has the biggest single impact of anything you would do. And so obviously, expanding Medicaid and paying for office visits is great. That won't change the fundamental issue of how health care is delivered.
Could I just add on to that? I don't disagree with anything that my firms from South Carolina have said. I think the social determinants of health are way beyond what's available at your local hospital or clinic, and they start very early in life, and we don't do a very good job in this country, really, of underscoring that with our children. And we gotta start teaching them when they're young. Unfortunately, that has a cost that and a payback that goes way beyond an election cycle. So it's very hard to get traction with that. But the establishment of free clinics, if you will, we have had a lot of experience with that, and it does change behavior. If you can give people access to a medical home, if you will, I know that term has some detractors, but a place that coordinates their care, both when they're well and when they're not well. And we've done that in North Carolina in a lot of communities, in Charlotte in particular, I'm familiar with. And when the access is available, the ER use goes down. And when the access fills up, in other words, if the clinics get so busy that it's hard to get an appointment, ER volumes go up. So we know that there's a direct relationship, and everybody knows that the ER route costs a lot more money. So in North Carolina, the hospitals have stepped up and suggested to the government of North Carolina that we would help to fund the incentives that would begin to cause changes in the way physicians practice, to do more on the medical home front, to do more in terms of prevention and trying to keep folks well and out of the emergency room.
But Michael, let me ask you something. Won't the physicians scream foul to say, well, if you're willing to do an incentive, whatever that looks like, why can't you just pay us more? Wouldn't that be a pushback?
This is coming from a separate source. This is really the hospitals getting behind this and working with the physicians. Right. The sensitivity on physician payment is incredible. In North Carolina, there was an experiment done years ago where physicians were being paid at 95% of the Medicare rate, and access was what it was. And in the next budget cycle, the state had some issues, some fiscal issues, and they lowered it to 90. And the number of people who stopped seeing, the number of clinicians who stopped seeing Medicaid patients was alarming. So there's a tipping point there, and it's real. And you're starting to see programs or reports nationally of physicians on the Medicare side too saying, I'm within a couple years of retirement, I'm going to go ahead and check out.
I made that comment earlier, and then I think we've got to come back to sort of a more macro view of this, because I think we really understand the serious bind the states are in. Mm-hmm. And
but let me ask you this, John, and I don't want to bang this home because you just made your case on why you're not taking these Medicaid dollars. But do you think we're going to regret not taking Medicaid dollars to fill this gap for 3 years or whatever that might be?
My answer is yes.
Yeah.
And it comes back to a point that Mike was making, and that is that as providers of health care, we're not just dealing with Medicaid, we're dealing with our combined set of economics. And the fact is, Affordable Care Medicaid expansion is being funded already by money leaving North Carolina and leaving South Carolina and not coming back because the one way to return it was through expansion. So there's this macroeconomic argument or point that we have to live with. And the other part of this is what your business viewership should be interested in, is that they are cross-subsidizing all these programs, because the way we stay in business is getting rates from commercial insurers that are sufficient to cross-subsidize our losses on Medicaid and Medicare that will get worse as we go forward. So the business community has a dog in this fight as well.
And Angelo, I want to ask you this, and I think this is important. Do those who make a dollar in healthcare that are non-agency organizations, do you agree that folks like Secretary Keck here and others that say, well, wait a minute, but we still got to fix this system before we pour money into the top of it and let it leak out like a sieve again? I mean, that does make sense, and we've all agreed with that at some point. It just seems like the timing of it might be wrong. I don't know.
Well, I agree. I think if I had my way, I'd have both. But we do need support from the state, dollar-wise, to change the fundamental way we deliver care. And I think long-term, that's the most important aspect of it. And I think we're thinking wrong if we think that the solution to health care is seeing more doctor visits. It's not. We're going to have a doctor shortage. Patients, even with insurance in our area, can't get doctor visits. And so it's really about outreach. It's about care management. It's about reaching out into the community, outreach, nurse practitioners, different models, different levels of reaching out to those patients and preventing them from needing a lot of those doctor visits. And so I think, again, I think both people have valid arguments, but I think unless we really focus on that new model of how we deliver it, it's just going to be a continued cycle of, more and more doctor visits, because that's not where the solutions get made.
It is a timing issue. I mean, it's an issue that I think a lot of industries face as they see their world changing, and they've got to change their business model. But at the same time, the current business model, the current way they get paid is to do X, Y, Z, when in reality, long term, they need to be doing ABC. And it's the same thing from a state legislative perspective. One of the problems that we have at these types of forums is that it's always healthcare people. There's nobody sitting at the table that's an educator. There's nobody sitting at the table that runs a manufacturing plant. There's nobody that builds roads. And so all of those people have arguments about where limited dollars should be going, whether they're dollars from the state or whether they're dollars from employers. We get a terrific match on transportation dollars from the federal government, about 83 cents on the dollar. So if we put up 17 cents, we get 83 cents of federal dollars to build roads and bridges and so on. And so there's good arguments that if you're looking to leverage your money, that you could leverage it in Medicaid or you could leverage it building roads. I had somebody the other day say, well, why do you care about roads? And it's because I'm part of a cabinet that is looking at total well-being of a state. And as a public health professional, if I truly believe in social determinants, not just lip service to it, but truly believe in it, I have to ask myself, is there money that's better spent someplace else that long-term is going to structurally change the health of South Carolina? It might be different in Massachusetts because of where they're at, but and I see part of my goal is freeing up wasted dollars so we can spend it elsewhere. Now, that doesn't help the 45-year-old woman right now who doesn't have insurance and has got 3 chronic conditions. And so at the same time, the state has to be investing in finding those individuals and taking care of them, because we are spending a lot of money on them right now. What our plan does is it's much more targeted, looking for folks who need help and getting them those services while we're working on improving value in the rest of the system.
And Anthony, okay, well, let me ask you that, because this is a good point. Does this debate, and you have to have open debate, I understand that, and your point is made well here. I don't think these guys are ganging up on you, but you're right. You are outnumbered here. But is this debate? I mean, how do you have such an intricate debate when we started out talking about reform and we're bogged down slicing and dicing Medicaid while it's an important piece? So I guess does the debate need to be, when you have so many people debating this, it is going to take forever to get to a decision. How do you shorten it down? And we have about a minute left for you to answer that. So anybody want to jump into that?
I don't think there's disagreement at a high level on any of this. And I think if there was somebody here from a manufacturing company, they would tell you, we can't afford to pay more for our health care for our employees, and we get that. But nothing that we're seeing really coming out in the way of reform really is aimed at reforming the way we deliver care. Now, we're working on that as individual organizations, and governments are encouraging that. But there are a lot of people working in silos on things that will have a direct impact on our ability to do what we have to do as healthcare providers, and that is we're going to have to do more. The population's aging. Medicare age people use more resources. There'll be fewer doctors. We got to do it in a higher quality and more efficient way. Meanwhile, you got the guys working in the silos that are. Well,
and I agree. It's a timing issue. It's a timing issue because we are already engaged, and the buses left the station in transforming healthcare. We just want to make sure we have the resources to do that, because I think it can be done in a few years.
John, that really has to be the last word. You know, we just started the dialogue, so thank you all for being such good sports about this and traveling. Good to see you again. Thank you for being on the program. Angelo, good to have you here.
Thank you.
Thanks again.
Thank you, John.
Thank you.
Good night.
Major funding for Carolina Business Review was provided by the Duke Endowment, a private foundation in Charlotte enriching communities in the Carolinas through higher education, healthcare, rural churches, and children's services. Blue Cross and Blue Shield of North Carolina. Who's responsible for rising healthcare costs? Join Blue Cross and Blue Shield of North Carolina and many others in a candid discussion at letstalkcost.com. Grant Thornton, an international accounting, tax, and business advisory organization dedicated to serving middle-market companies. Grant Thornton, a passion for the business of accounting. Novant Health, including Presbyterian in Charlotte and Forsyth in Winston-Salem, are affiliate heart hospitals of the Cleveland Clinic, consistently ranked #1 in the nation for heart care. Blue Cross and Blue Shield of South Carolina, proudly serving South Carolinians since 1946. Sunoco, a global manufacturer of consumer and industrial packaging products and provider of packaging services with more than 300 operations in 35 countries. And by viewers like you. Thank you. Promotional consideration provided by Business North Carolina Magazine. For more information, visit carolinabusinessreview.com.